So this again is just it's in the paper. I'm not going to spend a lot of time on it, but this was sort of a schema for what we consider high-risk relapse people with imaging, EKGs, and biomarker levels. So what about the medical management? I think this is a complete up for discussion. So first of all, you got to realize that this is a very heterogeneous group of patients. And I've shown you the epidemiology. Virtually everybody can recover their ejection fraction. So I think your clinical approach should take into account the etiology of the LV dysfunction. We don't really understand anything about the medications that are required to maintain a sustained remission. My understanding is that the TREAD-HF trial is now systematically withdrawing ACE inhibitors, beta blockers, and then spironolactone to figure out which elements are required. Based on the results of the TREAD-HF study, and this is only 51 patients, we think it's prudent to continue guideline-directed medical therapy in these patients unless there are mitigating circumstances. And the reason for that is that relapse of heart failure is associated with recurrent myocyte injury, and that makes it harder and harder to recover if you do resume medical therapy. We do think that cessation of diuretics can be considered in some patients. And if heart failure recurs after stopping the diuretics, this is really a bad prognostic sign, and those patients should have up titration of guideline-directed medical therapy. I think these concepts are not new. It's always amazing when I go back and look in heart failure to realize how little I've contributed to the literature. So we've known about these concepts. This is just readmission rates from Lynn Warner Stevenson's group, but this early initial peak here, I'm having trouble with my, here we go, pointer. When they first come in the hospital, this is the period of reverse remodeling. Then we've learned really how to treat these people. And this period of reverse remodeling and improvement in ejection fraction, this is really the period of remission where patients stay stable. And then there's this other group of people who have relapse. And this, many of the people here, as I've shown you, will go on and developing worsening heart failure despite being on the best medical therapy that we have, which is kind of scary. So why is this stuff so important? Today, you know, all hospital systems are being punished by these CMS guidelines, which say if you readmit patients with heart failure within 30 days, that you're not going to get reimbursed for that. And they attribute this to bad care. What I've tried to articulate this morning is I don't think it's bad care. I think it's bad biology. And the data for that are shown on this next slide, if I can ever bring it up. Yeah. So this shows temporal trends in readmission rates. And because of the CMS guidelines, they're certainly going down. But by the same token, you can see trends in mortality are going up. So I would argue that not readmitting these people tends to lead to worsening mortality and outcomes. So I want to conclude my talk this morning with a quote from Winston Churchill. This is not the end, it's not even the beginning of the end, but it's perhaps the end of the beginning. And I really think that over the last 30 years, we've gotten to the point where we can really treat these patients well. But now we have to understand why patients who ostensibly should be cured, they don't really have abnormal pumping capacity and they don't really have abnormal size ventricles, why they redeveloping heart failure. And I think hopefully we'll come to some new answers in this in the coming years. So with that, I'll conclude. And again, thank Arvin and Guillermo for the kind opportunity to speak this morning. I wish I could be there in person. Obviously, these are strange times. So thank you again.
Dr. Mann, thank you so much for that lucid and wonderful elaboration on a very interesting topic. I want to remind all of our viewers to go to pollev.com or text to DeBakey to 37607. You'll have that information on the screen with whatever questions. We have a good amount of time for good, lively discussion. I also want to point out there was some streaming issue for about 30-40 seconds, and in those specifics, if there are any questions, please put them on the question poll. And the whole grand rounds will be recorded without any streaming issues, so you can always go back to the recorded version and watch it. because as expected, every word that Dr. Mann said has some weightage in it, so I'm sure you won't miss it. But Dr. Mann, I think as questions are coming in, I want to open by, I've heard you say this before about the LVAD mafia and heart failure mafia. I think we need to form a recovery mafia and really focus on this fascinating field. My question to you is, and yeah, I think we shared some discussions before. Our lab is also focused on recovery with a model a little different than your work, where we've looked at natural recovery once the injury is gone. And
right.
I always wondered if when you look at the mice that recover, we're looking at the differences between the gene expression of the ones that recovered compared to during heart failure. But I always wondered if the mice that didn't survive did not have the genetic ability to recover. So do you think there is a switch that makes some people recover more? Despite beta blockers, we see not all of them recover. What are your thoughts on, are we missing the boat by not looking at those mice that actually didn't?
So it's a really good question. So first of all, rats and mice are really genetically pure. So in them, it would be hard to cull out a specific gene defect. In people, there's tremendous heterogeneity in terms of who recovers and who doesn't. It would be, I think, hard to believe that there's not some genetic component to that. In my own simplistic mind, I think that the amount of injury that one accrues during the forward remodeling process does sort of predetermine how much you can recover. A simple example would be if over time you progressively lose 40 to 50% of your myocyte mass, your likelihood of recovering is less. I mean, something has to make the heart get smaller. We don't have direct experimental data, but indirect experimental data, that if you look at return of contractility or return of contractile genes, it comes before the remodeling process actually occurs. So I think how you reverse remodel is also a really interesting question. I've spent a lot of nights up thinking about that, but it's not an elastic band that collapses. I think the sarcomere drives it, and then the matrix forms around it, which allows the ventricle to stay smaller. So I think if you can't get smaller, you can't reverse remodel. So the things that prevent that, certain genetic abnormalities for sure, and they've never done this, but I would predict that Titan abnormalities relapse faster. Again, that study's not been done. They certainly recover. And that people like the ischemics, like I showed you, where they have a myocyte deficiency, they don't recover as much. But in terms of the people who don't recover, who go on and die, I think it's probably going to be an admixture of missing components to recover, and then maybe some underlying genetic abnormalities. And we have no idea about how ion channels remodel in this. No one's really parsed that out. So it could be that certainly the ion channels don't recover and they're more prone to ventricular arrhythmias.
No, thank you for that. I think it to me, it almost gets overwhelming thinking about the complexity of recovery that goes on not just in the heart, the myocyte, the interstitial cells, and the systemic response. I think in that regard, we have a question here from the audience, and it's my partner, Barry Trachtenberg. He's saying, Dr. Mann, thank you for a phenomenal talk. I was wondering if the bioinformatics showed any role for ongoing inflammation as being more common in those that have not recovered.
Barry, hi. Good to see you. Not to see you, but good to hear from you. So there is a persistent inflammatory signature in one of our heart failure models. We've now detected chronic inflammation. There are more macrophages, despite the fact that the ventricle's recovered. Vili Topkara, who was a resident at Baylor and then came with me to St. Louis, actually did a really nice meta-analysis recovery, transcriptional profiles, and was able to show that one of the signatures of reverse remodeling was actually decreased in inflammatory genes. So he's got a really nice paper. I can't remember where it was published, but I would encourage you to look at that. So we think there's some evidence of chronic inflammation. I would love it if they were the ones that relapsed, and we're trying to test that hypothesis experimentally. But there is a certain reversal, and Guillermo's shown this really nicely with his earlier work, that unloading does lead to reversal of many of the inflammatory genes. In Guillermo's paper, it was tumor necrosis factor, but we see it all across the spectrum. Whether persistence of inflammation, low-grade inflammation, predicts relapse, we don't know, but a really good question.
I think with that, I'm going to see if Dr. Torre has some comments and questions. Inflammation is his field.
Yeah, so I didn't really want to push you into that field, Doc, but in understanding the biology of heart failure recover, and those that may relapse and those that may stay longer healthier, what would you think may be clues for designing interventions, or what is it that we really need to be looking at that may help us to design better therapies? Because at the end of the day, we'd like to maintain those healthier. And should we look more, what's your gut feeling? Is it more a myocyte issue? Is it the extracellular matrix and the fibrotic response? Are these peripheral humoral factors that affect how the heart is contracting in the interplay between myocyte and the extracellular matrix?
The answer is yes. So we've got another paper which we're trying to get through now. It's struggling a bit, but again, a resident. What we did was to look in our database at Barnes. We pulled out 1,000 people that recovered, and then we used machine learning to try to group the patients into different clusters. And then we're able to show that there were certain high-risk clusters and certain low-risk clusters. And the high-risk clusters did miserably. They were hospitalized or died. And again, in a large database like that, it's hard to have really accurate follow-up, which is one of the reasons we're struggling with the journals. But I do think there's a group of people, and not surprisingly, people who have conduction system abnormalities, and these were people that didn't qualify for CRT, but they did have a wide bundle branch. They were more likely to relapse. So I think my hope is that we'll be able to identify, based on clinical grounds, groups of people who are high risk, and then maybe get a better idea of the biology. It's hard, and I do think you could probably also come up with provocative tests. For example, look at contractile reserve with dobutamine or whatever, or figure out ways of looking at contractile reserve. The people who can increase their contractile performance with a stimulus would be more likely to withstand the hemodynamic stress. Those that
Do you have another question?
can't, I think if they got stressed, would be more likely to relapse. So I think we need to do better clinically to identify these people, but I think there are ways of parsing it out. But I can't tell you which specific part of the biology is abnormal that predicts relapse.
So Doug, let me follow that with another question, which is maybe more a philosophical approach, but as you and Arvin and I and Barry have dealt with many issues, how do we bring new therapies to heart failure where now there is a number of medicines that are highly effective and more that are coming up, so that if we want to test, let's say that we come up with a new pathway, how do we test it, and how do we go about in testing it in humans? And if you look at this particular subpopulation of heart failure, I mean, is it going to be feasible to test new interventions in these groups of patients?
Right. So I would argue to that question that this is a group of people that have never been studied before. They're all on optimal medical therapy. Now, we don't know about SGLT2 inhibitors yet, whether that prevents it. But every single one of the patients that we talked about in the studies that I showed you is on optimal medical therapy, and they're still getting heart failure. So this is different than developing a drug to prevent heart failure or to a new therapy to prevent heart failure or to stabilize it. It's a group of people who are on the best stuff we've got, right? And they still develop heart failure. And I think if you could identify the high-risk ones in there, you could come up with the trial to test either a new therapy, CBD. I don't know, but I think you could come up with a new therapy in that group of people. But the trick would be to come up with the really high-risk ones, because certain patients are probably going to do just fine, right? We know that not everybody on guideline-directed medical therapy comes back in the hospital, but about 40 to 50%, as I showed you in that Merlot slide, are at risk of redeveloping heart failure. And as I said, they're already on the best stuff we've got. So I think you can develop drugs in this space. I like you, worry about heart failure-reduced EF, because I don't think there's going to be a whole lot of wiggle room after the SGLT2 story. Now it's just SGLT2 1 and 2, it looks like, based on what was just released at the American Heart. So there may not be a whole lot of room for developing new HFrEF drugs. But heart failure recovery EF, as I said before, they're failing the best stuff we've got. So that's my argument for why we need new drugs there.
So I think we have quite a few questions coming in, and I'll try to combine a couple of them related to Gdmt. One of the questions was related to probably the TREAD-HF trial. They're asking, did the pharmacologic study specify which Gdmts were maintained or withdrawn? Which of the Gdmt medications work best for maintaining recovery? And I think another question maybe related to the trial was, can we decrease or de-escalate Gdmt for recovered heart failure with reduced ejection fraction?
Yeah, so all of these are really cutting edge questions. So first of all, they took everything away in a pre-specified manner, but I don't think they did one and then the other and the other. They just sort of reduced them quickly. My understanding is there's a TREAD-HF2 where there's testing which one you can remove, and then keep people on the other ones to see whether there's a constellation of drugs that are better. Chris O'Connor has talked about this concept of N-1 trials, where we, in a randomized way, would systematically take away one drug and then do outcome, take away another drug and do outcome. I think we need to do that, because if I'm a patient, at some point I'm going to stop wanting to take 5 or 6 medicines a day if I don't need them. Particularly if I'm really feeling well, if I'm New York Heart Class 1 and my EF's normal and you tell me I need to stay on 5 drugs, I'm going, why? Why do I need to do that? So we don't know yet. I think there are studies afoot that will address that. And as I said, I think where our field needs to go is this concept of N-1 trials. And as a clinical trial geek, I've really been enamored of some of these so-called platform trials that are going on in COVID, where they can test 10 therapies at once with a common control group. So what if you had a common control group and then you had one group with no beta block, take away the beta blocker, another group would take away the ACE inhibitor, another group would take away spironolactone. You could design a large N-1 trial with a common control group and maybe get a readout in 6 to 12 months. It would be a really interesting study to do. No pharmaceutical company, by the way, will support this.
Yeah, no, absolutely. And I think that kind of brings to some of the genetic aspects, and there are 2 questions which I can combine in asking about which cells will be the primary target, either cardiomyocytes or fibroblasts or extracellular matrix or immune cells. And related to that, should we be talking about a single gene pathway or should we be aiming at multiple gene pathways?
Yeah. So I'll address the second question first. We know from studies that certain gene defects will prevent patients from recovering their left ventricular ejection fraction. So based on that, I would think looking at a single gene pathway might be more instructive. Which cell types are critical for reverse remodeling? I don't know. As I said before, I think the myocyte is the sine qua non. You can't get a smaller heart unless the myocyte gets you there, right? But is that the thing that predicts relapse? I will say that in many of the reverse remodeling models, that the matrix doesn't change a whole lot. The caveat there is these are short-term studies in mice and rats, and the matrix may take 3 months to remodel, and we're doing this in a study in a month and a half. So it may be that the matrix is more important. But I think it is multi-level, right? I don't think it's going to be one thing. Initially, when I got into this, I thought, oh gosh, we're going to find a single gene defect, and we're going to be able to tweak that gene defect and then come up with a way to make everything better. It's so complex, and I showed you on this transcriptional profile plots, it's not a single gene pathway in the myocyte. The matrix is abnormal, the integrins are abnormal, the EC coupling is abnormal. All the elements of the myocyte are abnormal. A few things get better in the sarcomere.
Just find a comment if you
So, if you wanted to find a specific target for recovery, I don't think you can. It's way too complex. Hopefully, that sort of answered the question, Arvind.
No, I think so too. I've always wondered all those questions that our audience asks. I'm very refreshed to see a very engaging and well-versed audience that are asking these questions. One other question, probably kind of, I don't know if there's enough evidence, but somebody is asking, does regular exercise improve genetic signature that promotes recovery?
Really a good question. There was only one really organized study that looked at this, NIH-based study that looked at the effect of exercise. And what they were able to do was show reduced hospitalizations. Now, those were all heart failure reduced EF patients. I don't know what their EFs were at the time that they were exercising, but if one were to extrapolate from that to the current day, if somebody said to me, would exercise be beneficial? I would say, yeah. The one thing that we know from that NIH-based study was that it did prevent hospitalizations. We just don't know what the EFs were while they were exercising. I would suspect a certain cohort at the time of randomization may have had reduced EF, but by the time they were treated 2 months later and then in exercise regimens, they may have had recovered EF. So I think exercise does so many good things. It does unload the heart. It does reduce reactive oxygen species through enhanced nitric oxide generation. So I think it's the answer I would say is yes, but I can't give you a specific randomized trial. All I can do is extract or extrapolate from a prior one in whom they probably had some HFrEF EF patients in it.
Thank you, Dr. Mann. I think your last slide of your presentation was very appropriate, that we have a lot to achieve, and it's a fascinating area where we can probably, as you mentioned, we should plan on a recovery mafia, so the field really gets to a point where in essence you're imagining a day where we don't have to prescribe our patients 15 medications. As excited as we are as cardiologists, heart failure cardiologists, seeing new medicines, trying to modulate a set of genes to recover versus medicine sounds very lucrative.
I think we're going to get there, Arvind. I really do.
No, I think that
so count me in for the LNAD Mafia. I'll pay my dues now.
Absolutely. I think I was going to ask you to start it so we can be the members of it. But thank you again for your time today. As we come to the closing, I want to again guide all of our audience that the George P. Noon Conference will continue in a different link, and you can definitely find it on our website if you look for the George P. Noon Conference, where we have an exciting day focused on advanced heart failure, followed by durable mechanical circulatory support, and then followed by transplant. After this grand rounds, the next session will be kicked off by Dr. Ashrit Guha, who's the co-director for the transplant program, pulmonary hypertension, and advanced heart failure cardiologist. And as we wrap up, I'm going to let Dr. Torre kind of give some closing remarks, and we'll end.
Thank you, Arvind. So, Doug, I cannot stress the fact that that this was a beautiful example of how to bring basic fundamental concepts that will open up the path for more translational and clinical research work, which is really so exciting, and it's been perhaps one of the greatest motivation to continue to work in this field. And I kind of wanted to highlight that for maybe the fellows in the audience, or students, or younger cardiologists that are in the field, that I think they witnessed an example, even though Doug was very humble and didn't say that, but this work represents a very deep and thoughtful insight into not only the biology, but also the clinical setting, which is really not easy to obtain. And I think that I kind of wanted to highlight the importance of, for many of us that are continue to work in this field, the importance of understanding biology, but also the clinical perspective, that it makes a fundamental difference in how we approach the illness, and how do we bring new therapies to patients, which at the end of the day is what we all want to do. So Doug, it was really terrific, great to see you, and as always, a beautiful and extraordinary lecture. Thank you for your time and sharing everything with us.
Yeah, no, again, thank you guys. It's so great to be with you this morning, and as I said, I wish I could be there in person. So be safe, everyone, be safe.
Thank you. You too.